Should I start, sir?
Yes, you can start.
Okay. So, good afternoon and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the National Neonatology Forum Gujarat, and the focus of today's session is POCUS Series 25 USG Brain in PVL, Meningitis, Brain Abscess, Cerebritis, CMV infection. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. So, sir, you may proceed now. Over to you.
Thank you so much, Shriyashi. So it is with great pleasure we are completing our quarter century for the POCUS series. So our neonatal Pathshala is what we are doing every Wednesday between 3 to 4 p.m. And it is our one of the flagship programs of Gujarat State NNF. And in near future, we are also planning by I think in by month end with the help of Dr. Vishal, we are planning a neonatal nursing series also for similar online platform. So we'll be rolling it out soon. So thank you so much for all the participants for joining. Today we are lucky to have Dr. Usha Devi ma'am with us from Pondicherry. She will be covering a very important topic which is not discussed much in all the platforms, which is about the PVL, meningitis, cerebral abscess, and CVM. So we are all very eager to hear from ma'am. So thank you so much, ma'am, for joining with us. For further proceedings, I would request Dr. Vishal Goel, our project in charge, to take further proceedings. Thank you, Vishal. Over to you.
Thank you, Kunal. And I think Kunal mentioned that this one is an untouched topic. If I talk about the neurological emergency, not emergency, but neurological pathology apart from IVH. For that, we do have a renowned faculty from Pondicherry, Dr. Usha Devi, madam. She is an assistant professor and in Department of Neurology at JIPMER, Pondicherry, which is one of the renowned institute from India. Her main area of interest is extreme preterm care, NEC, and POCUS. She has more than 65 original articles, 14 chapters, editor for 3 books, associate editor for one. She also awarded more than seven for paper and poster in neonatology in national conference. So I welcome Dr. Usha, madam, and over to you, ma'am. You can share your screen.
Yeah. Thank you, Kunal sir and Vishal sir for the introduction. So let me share my screen.
Yeah, it's visible.
Yeah, okay. So we'll be seeing about cranial ultrasound in periventricular leukomalacia, meningitis, brain abscess, and cytomegalovirus infection, and in general in torch infection. So I would like to thank the National Neonatology Forum Gujarat chapter as well as Neonatal Pathshala team for the opportunity given. So without wasting time, let us go into the topic. Um, to start with, in the upcoming 45 minutes or so, we'll be seeing about these topics, and we'll start with grading of echogenicity. Normally, we see echogenic areas in the brain. So, how to grade that echogenicity and which one is pathological, which is normal? And periventricular leukomalacia types. What are the types as per textbook, and what are the findings we would get in a cranial ultrasound? And most of the times whatever we speak about is a cystic periventricular leukomalacia. So when we see cystic periventricular leukomalacia, how are we going to grade it? And we'll also be touching upon periventricular hemorrhagic infarction, which is a close differential to periventricular leukomalacia. And sometimes it might not, the PVL is not the classical cystic PVL, and there are other white matter injury types. So when there are other types of diffuse white matter injury, what are the subtle ultrasound changes which we can pick up? Also, we'll be covering upon ultrasound findings in meningitis, cerebritis, brain abscesses, and torch infection. Okay, so let us start with this echogenicity. We see a particular area in the brain echogenic. Normally, in a preterm baby, So we see for intraventricular hemorrhage, then we see the periventricular area. In the periventricular area, even in a normal preterm, the periventricular area appears to be echogenic. If the echogenicity or the brightness of the periventricular white matter is lesser than that of the choroid plexus, that is normal. Normally, all the babies will have some echogenicity there, but the brightness will be lesser than that of the choroid plexus. This is normal. This is grade 0 echogenicity, which every preterm is going to have. We need not worry about that. In grade 1 echogenicity, the periventricular white matter is bright, and the brightness or echogenicity is the same as that of the choroid plexus. So here, choroid plexus is a comparator. We are seeing the choroid plexus. We are using the brightness or echogenicity of the choroid plexus to compare our echogenicity in the periventricular white matter. So in the periventricular white matter, if the echogenicity is the same as that of the choroid plexus, then it is labeled as grade 1 echogenicity. So grade 0 is normal periventricular halo, where the brightness is lesser than that of the choroid plexus. It is normal. In the grade 1, it is almost the same as that of the choroid plexus. This needs follow-up. In the grade 2, there is seriously increased echogenicity. That is, the brightness in the periventricular area is more than that of the choroid plexus. This is serious. This might evolve into periventricular leukomalacia. Even grade 1 needs follow-up, whether the echogenicity is increasing or persisting. So this grade 0, we need not worry. Grade 1 and grade 2, where echogenicity is either equal to that of the choroid plexus or more than that of the choroid plexus, they need follow-up because they have potential to evolve into periventricular leukomalacia. So as we all know, periventricular leukomalacia is due to ischemic brain injury, which is typically seen in preterm neonates. There is some necrosis happening. There is softening of the white matter in that area, and there are some changes which we are going to look out by using different imaging strategies. So I hope all of you are clear with the echogenicity. So let us see some examples. Let us see some images and try to interpret. So here, this is a coronal view C5, where we are able to get the trigone. So if you see in this, we are able to see some fan shaped. Let me take the pointer. So we are able to have this fan shaped echogenicity in the periventricular area, right? But if you see, this brightness is lesser than that of the choroid plexus. These are the choroid plexus, no? So when compared to this choroid plexus, the brightness is lesser than that of the choroid plexus. So this is grade 0 echogenicity, which you are going to see normally in a preterm baby, which is normal. So this is a sagittal view, S2, S4, angled parasagittal view, where you are getting a echogenicity in the periventricular white matter, which is lesser than that of the brightness is lesser than that of the choroid plexus. So this will amount to grade 0 echogenicity. The same thing. If you see your left side, if you see in the S2, S4 angle parasagittal, the periventricular white matter, yes, there is a halo, but the echogenicity is less than that of the choroid plexus. So this is grade 0 echogenicity. But if you see to your right side, in the frontal area, you are able to see some cystic transformation. This cannot be taken, and even in the posterior part near the occipital, you are able to see the cystic transformation. This one you cannot take it as normal. This is non-physiological. Probably this is a periventricular leukomalacia. So here again, this is a periventricular halo, whereas towards your right side, you are able to see in the this is C5 view, but you are able to see some cystic transformation which are present adjacent to the ventricles. So this cannot be normal. Even here, if you are able to see, it is not very clear, but there are some cystic transformation. So this is not physiological, no? This is something pathological. So we saw about grade 0 and physiological things, and when do we think, no, this is pathological. So now coming to the next grade. Here, if you see, some part of the periventricular white matter is as bright as a choroid plexus. This is a choroid plexus, and some part, you get this periventricular halo, and some part are as bright as choroid plexus. So this will amount to grade 1 echogenicity. Grade 1 echogenicity we cannot neglect as it is. You need to follow at least after 5 to 7 days. At least after a week, you need to do a ultrasound and see whether brightness has increased, whether it is persisting or there is some cystic change. You need to follow it up. So here we are able to see some like periventricular halo is present and some areas are bright and there are few spots which are more brighter than the choroid plexus. So kindly don't mark in the screen. Okay. So okay, if you see some parts are even more brighter than the periventricular white matter. So here you are able to see this is a C6, last in the occipital area. You are able to see some bright spots. If you see itself, you know that this echogenicity is totally abnormal. We don't get normally like this. So these are all grade 2 echogenicity, which are not normal. So this is how you see. You get this periventricular white matter. As we all know, it is present dorsal and lateral to the lateral ventricle. Dorsal and lateral. This is the area which we are targeting. This is the area which you will be looking at when you are doing ultrasound cranium screening for a neonate, for a preterm neonate. And in the again, this is sagittal. This is coronal showing the trigone view. Here also we are targeting at the periventricular area where we are looking at whether there is any grade 2 or grade 1 echogenicity. Same way in the sagittal view. So here parietal occipital. Usually we are able to see in the parietal area abnormal echogenicity. And when it is extensive, this is an angled parasagittal, no? S1, S5, the extreme sagittal view, parasagittal view, where you will be able to appreciate the changes in the periventricular area. You might be able to see an extensive PVL starting from the frontal, parietal, and extending into the occipital area as well. So grading of PVL is also there, which we will be seeing subsequently. So I'll not be going into much of theory. I'll be concentrating on the ultrasound findings to just for completion's sake. So main pathophysiology, if you take for periventricular leukomalacia, there are few factors which make this periventricular. Why it can involve subcortical area, it can involve other areas as well, no, in the posterior part. But why the periventricular area is particularly more prone? Means there are some factors, there are some physiological deficits which make this periventricular area more prone to leukomalacia or the ischemic damage. So this is a periventricular area. If you see, perfusion is from different vessels. There are long penetrators which are coming from the middle cerebral artery. There are short penetrators. Mainly these long penetrators, they supply the deep periventricular white matter that is near this area. And there are some short penetrators, vessels, arteries, which supply the subcortical or superficial white matter. Usually, as when the baby is between 22 to 32 weeks, that is a very preterm. In a very preterm neonate, the number of long penetrators is less. And even short penetrators are very sparse. And the anastomosis between them, anastomosis among the short penetrators, anastomosis among the long penetrators is also very less when the baby is a very preterm. And the walls are also not supported. We tell no, even in intraventricular hemorrhage, we say these capillary walls are not supported. The endothelium is not well developed. So what will happen? So they are more prone. Autoregulation is not there. They are more prone to, this is like a vascular border zone. And whichever few vessels are supplying, those are also not well developed. So this zone is more prone to ischemic damage, and hence we get this periventricular leukomalacia in this area. Okay, this is a vascular factor or the deficit which makes this area more prone to the periventricular leukomalacia. Second thing is impaired autoregulation. So we all know that whenever BP is fluctuating, what will happen? When the BP is increased, when the blood pressure is on higher side, what will happen? So the vessels will constrict, cerebral vessels will constrict to restrict the blood flow to the brain. When the blood pressure is low, the vessels will dilate to give adequate blood flow to the brain area. So this is called as, so as the blood pressure fluctuates, the cerebral vessels also undergo something called as auto-regulation, and cerebral blood flow is auto-regulated. But since the vessels have this inherent deficit, this auto-regulation is very, very poor in a preterm neonate. So this will not be in a wide BP range, this will be in a very narrow BP range. So any minor fluctuation of blood pressure, any hypotension, any hypertension can lead to ischemia and periventricular leukomalacia. Increased vulnerability. Why it is more vulnerable means, in this periventricular white matter, you have more of pre-myelinating oligodendrocytes, which give rise to oligodendrocytes, mature oligodendrocytes. And these oligodendrocytes are very important for migration of axons as well as for myelination. So when this area undergoes ischemic hypoxic damage, there is also some of the free radicals which are getting released. There are also some of the excitotoxicity. So this pre-OL, oligodendrocytes are affected. There will be oligodendrocytes maturation arrest. There will be impaired myelination, impaired migration of the axons. There can be pancellular death of the cells happening, and microglia, astrocytes, all these cells can be affected. There can be necrosis, there can be cystic periventricular leukomalacia, loss of glia, loss of axons, and white matter volume as such will come down in this baby who is undergoing ischemic hypoxic damage. So there can be focal necrosis. So PVL types, if we come to PVL types, there can be focal necrosis or there can be diffuse gliosis. So most of us are speaking, why are we doing a serial ultrasound cranium? In a preterm baby, we have a unit protocol which says within 72 hours you need to perform the first ultra. This I am saying for a asymptomatic baby. For a symptomatic baby, you will be doing at the onset of symptoms only, and you will be repeating according to the pathology you have found out. But in a asymptomatic preterm baby also, unit protocol says first ultrasound, screening ultrasound cranium you will do in the first 72 hours. And the repeat scan you will be doing around 1 week. And even if all the scans are normal, you will be repeating the ultrasound cranium screening at 1 month, that is 28 days of life. Why do we do that? Because initially you will have this increased echogenicity, which we were speaking about. Grade 1, grade 2 echogenicity. Slowly the echogenicity will be persistent, and by 1 week you will be able to see the cystic transformation, which we call as cystic PVL. Though we talk more about this cystic PVL, cystic transformation, we need to remember that cystic PVL constitutes only 3 to 5% of the total number of periventricular leukomalacia. The remaining varieties, that is the non-cystic or the microcystic variety, microscopic cyst variety, where there is only glial scars, it constitutes 25, around 25%, and the majority is the diffuse variety of the periventricular leukomalacia, where there is decrease in the pre-myelinating oligodendrocytes, and they are not able to regenerate. There is some white matter loss happening. There are some gliotic changes. All this subtle white matter changes, which will be very, very difficult to pick up in the ultrasound cranium. So the cystic PVL, which we most commonly talk about, constitute the least common variety of periventricular leukomalacia. The rest are the non-cystic or the microscopic cyst variety, and then diffuse gliosis variety. So we'll be seeing about each type. So you have a macroscopic cyst, which is a cystic PVL, where each cyst will be approximately more than 3 mm in size. When it is less than 3 mm, it is very difficult to make out in the ultrasound cranium. This forms the microscopic cyst variety, or sometimes called as non-cystic variety. And the diffuse gliosis thing, where there is no cyst at all. So this will involve the whole of the periventricular white matter, and there will be only subtle white matter changes, which also we'll be discussing in the subsequent slides. Okay, if you see, this is an anatomical specimen after when they do autopsy after the death of a preterm baby. This is an anatomical lesions, a post-mortem seen in the brain. So here you are able to see some discoloration in the throughout the periventricular white matter. If you see, this is probably a older baby who has developed frank cystic periventricular leukomalacia, where you are able to entire periventricular area has been changed, has undergone a cystic transformation. Here, if you see, there are some gliotic changes, no? Gliotic scarring. the bright echogenic spots in the periventricular areas. There is some gliotic scarring. Also, there are some cystic transformations, small cyst which you can make out in this anatomical specimen. Okay, so now we know how to grade the echogenicity and we know why periventricular leukomalacia happens. What are the physiological deficits in a preterm baby leading to periventricular leukomalacia? We have also seen like what are the types of PVL, and we have seen that cystic PVL is the least common variety. Other lesions are more common. We have also seen why periventricular white matter is more prone, and this oligodendrocytes or the premiyelinating immature oligodendrocytes are more concentrated in the periventricular leukomalacia, and they are more prone to be affected by hypoxia ischemia. They are more prone to be affected by excitotoxicity, your glutamate excitotoxicity, free radicals, all those things. So based upon this, now we will see some cases and we will try to grade, we will try to identify whether it is periventricular leukomalacia. We will try to grade the periventricular leukomalacia. Okay, so first of all, we should know how do we go about grading of periventricular leukomalacia by D-Rees classification in an ultrasound cranium. So we saw in the example also we saw no grade 1, grade 2 echogenicity. So when this grade 2 echogenicity, periventricular echo densities or flare is persisting for more than 7 days. Okay, so once you get a grade 1, grade 2, you don't stop with that. We already saw that we'll be repeating the serial ultrasound cranium. So 5 to 7 days when we are repeating, when it is persisting for more than 7 days, this will be classified as grade 1 periventricular leukomalacia. When the transient periventricular echo density has subsequently evolved into localized cyst in the periventricular area, that is grade 2 periventricular leukomalacia. When the echo density is evolving into extensive periventricular cystic lesions involving the frontoparietal occipital area throughout, we saw on the sagittal plane, we saw it can extend from the frontal area to the occipital area. When it is extensively involving the periventricular area, this will form grade 3 periventricular leukomalacia. When the densities are extending into the subcortical white matter also. Okay, when the whole brain is getting transformed into cystic encephalo, undergoing a encephalomalacia, there is no brain parenchyma. Everything is appearing like a cyst. I am not able to differentiate which is lateral ventricle, which is a cyst. When there is so much extensive encephalomalacia, it will account for grade 4 periventricular leukomalacia. Okay, so let us move on to this case. Very preterm baby, 30-weeker, birth weight of 960 grams, absent end diastolic flow. Baby had RDS, received surfactant, subsequently developed culture positive sepsis. So this was an ultrasound cranium which I had done on day 4 of life. I'm able to see echogenicity in the periventricular area and some part in the immediate periventricular area. I am seeing a echogenicity which is slightly more than that of the choroid plexus. So I'm labeling it as grade 2 echogenicity, but yes, I wanted to repeat it. I wanted to see whether this echogenicity is persisting for 7 days. So on day 11, I'm repeating the ultrasound cranium to see what has happened to this echogenicity. You can see that the echogenicity is well formed in the periventricular area and it is brighter. This is C5, no? So if you see the choroid plexus, it is brighter and it has become permanent, no? It is persisting for 7 days and it is seen all over the periventricular area. So now I will classify this periventricular leukomalacia as grade 1 periventricular leukomalacia. In the day 4, in the sagittal view, I was able to see some echogenicity in the periventricular area. When I repeat, which is not normal, when I repeated after 7 days, I could see there is a well-formed echogenicity, brighter and present all over the periventricular area. So directly, yes, this baby is having periventricular leukomalacia. I need to serially follow up to look for cystic transformation. So this is a grade 1 PVL. Okay, I myself told the answers. Okay, so now I'm able to see some cystic transformation which is restricted to the periventricular white matter. So what is this grade of PVL? You can type in the chat box. So now we are having the cystic changes which are restricted to the periventricular area, mostly in the frontoparietal area. So what is this type of PVL? Yeah, you started typing. Okay. So this is grade 2 PVL where it was restricted to the here it is restricted to the periventricular white matter. Okay. Grade 2 PVL restricted to the periventricular area. Grade 2 PVL, see, you are typically seeing in the frontal area, frontoparietal extending into the parietal. Here you are able to see in the periventricular area, grade 2 PVL. Yeah, this one has answers already. So here you are able to see not only in the periventricular area, it has started exceeding the area as well. And this is a C6, no, the coronal when you sweep from anterior to posterior, this is a posterior most view. You wanted to see the occipital white matter, but instead of occipital white matter, you are able to see a fully cystic transformation. So these are extensive PVL, no? So this is grade 3 PVL. Here also in the sagittal view also, you are able to see the cystic transformation in extending into the occipital area. Here this is a tangential S1 S5 is a parasagittal view where you are able to see the cystic transformation extending into the occipital area. Okay, so you are having an extensive cystic transformation. You're having extensive cystic transformation extending. You are having an extensive cystic transformation extending into the occipital. It is also present in the frontoparietal area. It is extending until the occipital area. Okay, this was a preterm culture positive sepsis, had shock, was on multiple inotropes. So here also you are able to see this is a S1 S5 sagittal parasagittal view where you are able to see the cystic transformation. Here this is a view through the posterior fontanel. This is not anterior fontanel views. This is across the posterior fontanel. Usually we try to see the occipital area. In this here we are able to see cystic transformation in the parietal area, frontoparietal area, even in the occipital area. Instead of brain parenchyma, I'm able to see some cystic transformation. This is obviously grade 4 PVL, no? Entire brain parenchyma has undergone cystic transformation. So, which is ventricle, which is cyst? Here it is very difficult. If you see which is ventricle, which is cyst, I'm not able to differentiate at all. The entire parenchyma has undergone encephalomalacia. Okay, so encephalomalacia. Here also you see entire brain parenchyma has undergone cystic transformation. There is no brain parenchyma at all. Fully it has been filled with cyst only. Okay, so this is how they evolve. Suppose grade 2, grade 3 PVL, should I be happy if it is grade 2 only, not grade 3? Sometimes grade 2, grade 3 differentiation is very difficult. Doesn't matter. Anyway, baby has periventricular leukomalacia and it has started to have cystic transformation. So anyway, there is high chance of baby ending up having spastic diplegia, high chance of having some visual defect. Even the upper limbs can be involved if some part like we say centrum, semi-ovale, all these parts are involved. Even upper limbs can be extensively involved. There can be classical spastic diplegia. So this baby is high risk and requires high risk follow-up and early stimulation and exercises, physiotherapy, occupational therapy, all this. And so prognosis is guarded, whether it is grade 2, grade 3 or grade 4, we need to follow up this high risk babies. Okay, so this is how it is going to evolve. And so initially you see echogenicity. In 2 weeks, I was able to see some cystic transformation happening. And by 1 month, I'm able to see clear-cut cystic transformation. So this was a MRI taken at school age, which is showing that, so when the white matter decreases, what will happen? It is like hydrocephalus ex vacuo, no? The ventricle appears to be prominent, becomes big. There is ventriculomegaly. It is not because of increased CSF. It is because of decrease in the white matter. So you can see this trigone area, no? It is appearing like bigger. It is small. It is appearing bigger in size. There is is ventriculomegaly, and if you see in the peritrigonal area, there is some echogenicity. So this is how PVL is going to evolve. As I said, yes, prognosis for PVL after diagnosis, can I reverse it? No, already damage has happened. Already there is apoptosis. Already there is liquefaction, necrosis. There is cystic transformation. His prognosis is guarded. That is what I'm going to say, whether it is 2, 3, or 4. Okay, so white matter injury, we saw that, yes, we were discussing about how to grade a cystic PVL. There can be microscopic necrosis also, which you might miss in ultrasound cranium, which might be picked up only in MRI. So not MRI, so 70% of the non-cystic variety, that is microscopic cyst or diffuse gliosis, cannot be picked up by ultrasound cranium. Only 30% of it will be picked up. And yes, of course, cystic PVL you will be able to pick up by ultrasound cranium. And even the diffuse white matter gliosis will have some implication, no? They will have some developmental delay, they will have intellectual delay, motor deficits will be there. So that also, which is not picked up, if it is not picked up by ultrasound cranium, it doesn't mean that baby is not having PVL. They can have the other types. They can have the diffuse type. They can have the microscopic cystic type. Then also baby will have some deficit. So we cannot rule out PVL just because your ultrasound cranium did not pick up any cyst. Okay, even with MRI, 30% of this other diffuse white matter injury types cannot be picked up. So that is a limitation, no? So only we are saying, yes, it's a very preterm, this will be high risk baby, this requires a follow-up. This is requires a meticulous follow-up, even if the ultrasound cranium is normal. Okay, so can we not make out, if it is not cystic PVL, can I not make out this white matter injury at all in ultrasound cranium? Yes, you can see some changes which is indicative of white matter injury. So what are those changes? See here, normally this is an interhemispheric area, no? This is an interhemispheric area. Normally you don't see this much space. Okay, normally, okay, in a preterm there will be space, but subsequently as a baby grows, this interhemispheric space will decrease. You will not be able to make out this much space. In the term equivalent, you will be able to see changes when there is diffuse white matter injury or white matter loss. Yes, there are some subtle changes which will indicate, yes, this fellow has some white matter injury. See, there is so much separation. There is the interhemispheric width is so much increased. The subarachnoid space is so much increased. You are able to see the convolutions very prominently. Okay, and this space should not be this much, no? Cranium to this hemisphere, this brain. So this distance is so much increased. Interhemispheric also, there is so much widening of the space. And you are able to see this ventricles also appears very prominent. There is ventriculomegaly because the white matter, there is some white matter injury, white matter loss, which has caused something like ex vacuo. There is a ventriculomegaly. Okay, so this ventriculomegaly and spaces are increased. This all indicates, yes, there is some white matter loss which has happened in this baby. And if you see, whenever there is increased intraventricular pressure, this enlargement of the ventricles will be convex. It will be like this. It will be rounded. But when it is due to ex vacuo, when there is a decrease in the white matter and ventriculomegaly happens, it is a concave, no? There is ventriculomegaly, but this border is concave. So these are some subtle things which when you develop expertise, when you do again and again, you will be able to recognize this diffuse white matter injury types also at term equivalent, even with ultrasound cranium. So these are some objective markers. So as I told, the convolutions are very prominent, spaces are increased, and these are some of the markers. So ventriculomegaly, no? So this ventricle roof to floor distance will be increased because the ventricles are enlarged. The lateral ventricular index will be increased because ventricles are enlarged. The interhemispheric width is increased. The sinocortical width is increased because the subarachnoid spaces are increased and the white matter as such has decreased. So there are some this one measurements given in volt P, like the ventricular index when it is more than 13 mm, when the frontal on of the lateral ventricles is increased, when the mid body is increased, there will be thinning of the corpus callosum. So the thickness of the corpus callosum will come. The sinocortical width or intrahemispheric width will increase. These all indicate that there is white matter loss. Okay. So we saw about cystic PVL. We saw about some subtle changes which will indicate there is a white matter loss when there is diffuse white matter injury. There are some changes as well. There are some other changes, like you are able to see this term equivalent. I'm doing ultrasound cranium. See, there is some gliosis which has happened. You are able to see a hyperintensity. You are able to see a echogenic area in the periventricular area. You are able to see a single other changes also you are able to see more of convolutions, more of increased subarachnoid space. You are able to see some cystic transformation. Here, if you see in the parasagittal view, you are able to see some echogenic spot in this, which is not normal, probably a gliotic scarring. Here you are able to see a term, initially you didn't see, but a term equivalent, you are able to get some echogenicity, also cystic transformation. Even here you are able to see that there is sinocortical width, that is increased spaces are seen. Okay, there is punctuate gliosis seen. There is some cyst seen. There is some hyperintensity, no gliotic changes seen. There is punctuate gliosis. Ear echogenicity, ear echogenic spots. These are seen. So commonly, no, people mistake this hemorrhagic infarction and periventricular leukomalacia. Both are close DDs. Usually, periventricular hemorrhagic cystic PVL is because we saw no these arteries, long penetrators, short penetrators. These arteries are not or very less in number. Anastomosis is poor, so they are not supplying properly. So that is arterial infarct. This periventricular hemorrhagic infarction, what happens is you have a massive hemorrhage inside the ventricle and it compresses the vein. So vein is not able to remove the blood from the periventricular area. So it is a venous infarct. Usually it is present on the side where there is intraventricular hemorrhage, grade 3 intraventricular hemorrhage. Or sometimes grade 2 also. So this is compressing the vein and you have PVHA on that side only. Okay, in the normal side, you will not see this change. Whereas PVL is bilateral, it is symmetrical. And here, if you see hemorrhagic infarction, when it happens in the side of IVH, it is a clear fan-shaped regular border infarction. Okay, whereas this border will be irregular. And as we all know, PVL, when did we get the cystic changes? We got the cystic changes only by 3rd or 4th week. Whereas this cystic changes in the side of IVH, no, when there is PVHI, you will be able to see even in 24 to 48 hours. It leads to faster progression. And usually the cyst formed will be a single or two a large porencephalic cyst. Whereas in the PVL, we saw no, in the sagittal, multiple like honeycomb-like appearance, multiple small cysts will be seen. Okay, so this is seen in the side of IVH. This is usually bilateral and symmetric. What happens when there is hemorrhage? So normal drainage is via the terminal vein, terminal part of the medullary vein, which is draining the periventricular white matter. This will take the blood and it will drain into the internal cerebral vein. So what happens when there is IVH? This compresses the terminal part of the medullary vein, connector vein, and there is a venous infarct in this side. Okay, so the borders will be fan shaped. It will be like a irregular infarct. Whereas here the PVL, it will be bilateral, symmetrical, but the borders will be totally irregular. Okay, so this is how PVH is going to. I had a grade 3 IVH in the left side. So only the left side is showing this echogenicity. And within few days, it is getting transformed into, there is a cystic transformation. 2 cysts are formed in the periventricular area. You can see that there is a ventriculomegaly because this is grade 3. There is ventriculomegaly. On that side, you are getting this cystic transformation. The opposite side, it is completely normal. So same way, there's a fan-shaped echogenicity on the side where there was extensive IVH. So regarding PVL, let us see some few points and then go to the next pathological condition. So we know that it is all because of prematurity and maturation dependent factors. There is a pressure passive circulation, vascular deficits is there, oligodendrocytes, pre-oligodendrocytes or have increased vulnerability and they are more in the periventricular area. So periventricular area is more prone. We have to grade the echogenicity. Always when you do a screening ultrasound within 3 days and you find echogenicity in the periventricular area, grade it. If it is grade 1, grade 2, don't leave it at that point. Serially follow it up for cystic transformation because that is needed for prognostication. And cystic PVL, which we commonly discuss about, is a least common type, and we need to know how to differentiate from the periventricular hemorrhagic infarction. And even in the non-cystic types and the diffuse white matter gliosis type, we can see some evidence of white matter injury, white matter loss when serial scans are done till the term equivalent. Okay, now let us move on to the bacterial meningitis. So I'm not going into theory. I will just discuss what findings we'll see in the ultrasound cranium. Okay, so we'll be seeing some increased echogenicity in the brain parenchyma as such, and it is very, very difficult. Are you able to see where are the lateral ventricles in the C2 view? No, it is very difficult to see the ventricles itself in the coronal view. It has got completely obliterated. So this obliteration of the lateral ventricles and increased echogenicity, even the sulci and gyri, some Sylvian fissure, okay, I am able to see, but sulci and gyri are not. Sulci and gyri are appearing prominent or appearing echogenic. We'll be seeing some more images in the subsequent slides where the sulci and gyri are effaced and appear prominent. And here there is obliteration of the lateral ventricle as well. Okay, next coming to ventriculitis, when there is persistent infection, what happens? There can be the debris might go and block your foramen of Monroe, or it can go and block your aqueduct. And what will happen is the drainage of CSF will get affected. There can be ventriculomegaly, and there can be infection of the ventricle as such. So this is called as ventriculitis. No, how do we suspect ventriculitis? In ventriculitis, there is a thick ependyma. This borders of the ventricle, if there is ventriculomegaly, obviously, and the borders, if you see, it is appearing brighter than what we see normally. And in the right side, I'm able to see this marker is supposed to be in the right side. In the right side, I'm able to see some septation as well in the base. Okay, some septate, compartmentalization, echogenic ventricular walls. If you see here also there is some septations. Here if you see, we can clearly see this Monroe getting blocked. There is some debris which is getting deposited in the base of this lateral ventricle and blocking at the roof level, third ventricle roof level, blocking the foramen. And this will subsequently lead to ventriculomegaly, and index will be more and more increasing. So we are able to see the prominent walls of the ventricles. Even here the sulci and gyri fissures are appearing very prominent. So here also we are able to see some septations in the left ventricle. So here we can see massive ventriculomegaly, probably due to obstruction of the foramen. And we are able to see that the walls are very bright and echogenic, which might indicate that there is ventriculitis. So usually we give in ventriculitis, on meningitis, how we give for 21 days. Ventriculitis, we usually give for 4 to 6 weeks, and we see whether this debris and the septations are getting resolved also. When we give a sensitive antibiotic, this might resolve also. Sometimes when there are excessive septation, there might be a localized collections, and the antibiotic therapy might not be effective. People go for intraventricular antibiotics as well in these cases, and go for some neurosurgical procedures as well to break those septations, so that the penetration of antibiotics and efficacy of antibiotics is improved. So we are able to see the sulci and gyri, they are very effaced, appear echogenic. And here in this image, I'm able to see, first of all, there is ventriculomegaly. Normally in this C3 view, we won't be seeing this temporal horn of lateral ventricle. But if you see frontal horn, usually you see frontal horn which is getting dilated in ventriculomegaly. When there is massive ventriculomegaly, even the temporal horn we are able to see here. Temporal horn also is appearing dilated. So there is a significant ventriculomegaly, probably due to obstruction at the level of aqueduct or obstruction at the level of foramen. Even third ventricle appears to be dilated. So there is aqueduct which has got obstructed. And the walls are also appearing very echogenic. And here we are able to see a echogenic wall in the lateral ventricle, and fully this is filled with some debris. No, we are able to see some echolucent substance inside the ventricles. Here we are able to make out a demarcation between the pus and the debris. So the arrow is showing this demarcation as well. Here we are able to see many septations in the ventricle. All these are directly indicating that yes, this baby doesn't have meningitis alone, he has developed ventriculitis. And here you are able to see a massive cystic structure to your right. And what happens is this structure is almost compressing, and the midline is shifted towards the opposite side. There is echogenicity in the opposite side also. Probably this might be an abscess. So whenever there is abnormal increased parenchymal echogenicity alone, ventriculitis, you are all clear. Walls are prominent, there can be ventriculomegaly, and the debris is going to obstruct your foramens. There will be septations, there will be debris collections. All these things indicate that yes, this is ventriculitis. But when there is abnormal echogenicity seen, sulci are appearing prominent, abnormal echogenicity, it might be due to cerebritis. It might be a sign of early abscess formation. So abscess will require some time to form like a well-formed circular circumscribed lesion. So it might be early sign of evolving abscess. Might be increased echogenicity might be seen in infarction as well, and can be seen in hemorrhage as well. So when there is increased echogenicity as such, it indicates there is a poor prognosis and there is high chance of neurological sequelae, and we need to follow it up whether it is transforming into an abscess or clear-cut ventriculitis feature you are getting. So we need to follow it up. Coming to the cerebral abscess, so we saw about meningitis, then complication ventriculitis, then another complication cerebral abscess. So commonly we used to read Citrobacter means that this is a common MCQ question. Which organism is associated with a cerebral abscess in a neonate? So A, B, C, D, we will select Citrobacter. So Citrobacter, Enterobacter, Serratia been known to be associated with cerebral abscess. But nowadays, we even come across all these resistant strains. We also come across E. coli, Klebsiella, and Group B Streptococcus. All these infections also can lead to cerebral abscess formation. So initially we told the cerebral abscess can be like increased echogenicity only. You see there is an increased echogenicity in the frontal area. Okay, this is inverted the images, so it might be confusing. This is occipital area. So in the frontal area, I am able to see some increased echogenicity. Okay, if I put a Doppler, whenever there is an infection, the vascularity appears to be increased. So it might be appearing increased when if you put a Doppler color flow. So here, when I serially followed it up, we could see well circumscribed solid mass, and you are able to see some debris also, some lines separating this black and white debris. So this is how it has evolved into a cerebral abscess. Of course, these are all very important to decide whether how many weeks of antibiotics you need to give, and how to do serially ultrasound to look for resolution of resolution of the abscess. So here you are able to see a well circumscribed abscess, and there is cavitation as well here. And when you put a Doppler, there will be hyperemia as well. So here there is abscess, there is some debris collection in the left side, left hemisphere. So this is left, right? So then the right side, there is some cavitation, abscess, debris also you are able to see here. So again in the right side, abscess. Here it is, this is marker is here. So this is right. So in the left side, you are able to see a well circumscribed solid lesion with some debris inside. So this is what will happen. So there is a meningitis in this baby. All this sulci are appearing very effaced. Also, there is some white matter damage. The convolutions are appearing very prominent, or it is a very preterm baby. And when you put a Doppler in this baby who has some meningitis, you are able to see increased vascularity. So it can be, see, there is some collection in the subdural area, and you know that clinically, CS of analysis wise, this baby is having meningitis. So should I take it as just a subdural effusion collection, or should I take it as subdural empyema? So when there is stance here, if you have stance and some collections, even here you are able to see, no? Yeah. So this is a subdural empyema, probably. You are able to see some debris here. You're able to see some debris in the subdural area here. So this is probably a evolving subdural empyema. This is not a clear-cut fluid collection alone. So this is getting transformed into a empyema. So when there is infection, whenever you put vascularity, you are able to see around the borders, around the corners, you are able to see increased vascularity. So this increased vascularity will not be seen only if there is any fluid collection or effusion. It will be seen when there is meningitis, when there is empyema. When there is infection, you will be able to see this fluid, increased vascularity. So color flow Doppler is important to differentiate between the empyema and effusion if you have doubt. Obviously, this baby has some debris collection here, no? So this is a subdural empyema. So let us now move on to the torch infection. So in the torch infection, these are the findings. Most of it you would have read in theory, you would have seen in your cases also. In cytomegalovirus, you get this periventricular punctuate calcification. So, excuse me, 1 minute. So in the cytomegalovirus, you will be able to see this periventricular punctuate calcification. In toxoplasmosis, we know that this is not periventricular, this is an extensive calcification. Mainly in toxoplasmosis, there will be involvement in the cortex, basal ganglia, thalamus, everywhere. There will be involvement in the periventricular white matter. More of calcification, echogenicity, you will be seeing in the periventricular area. And in Zika virus, you will be seeing calcification many times. When there was a period where there were Zika virus infection more common. Baby will come with a microcephaly in utero Zika virus infection. So baby will come with microcephaly. When you do ultrasound cranium, there will be calcification. You will be thinking that is toxoplasmosis or cytomegalovirus. But when you do send a viral PCR, that will be showing that it is positive for Zika virus. So here there won't be toxoplasmosis will have a predilection to involve basal ganglia, thalamus, and periventricular white matter, whereas Zika virus doesn't have that. And it will have a diffuse calcification in random areas. There will be microcephaly in all of these things. And in rubella and all, you can have additional features like subependymal cyst. And even in parvovirus, there can be ventricular dilatation, though we don't see it commonly. And all this torch infection can have lenticulostriate vasculopathy. So what is lenticulostriate vasculopathy? We'll be seeing, I won't be going into the theory, I'll be showing some images which will show the lenticulostriate vasculopathy. Okay, so these are some of the, this is a case of cytomegalovirus where you are getting cyst. In some cases, you can get, there is cyst also. And walls, if you see in some area, it is highly echogenic. Here again, there is a periventricular cyst. Here, if you see subependymal hemorrhage, it is looking like subependymal hemorrhage, some cystic transformation seen here. And here, subependymal area, there is some cystic transformation. Here, you are able to see clear-cut echogenic spots, So, you are able to see probably calcification. And here in the parasagittal view, in the angled parasagittal view, you will be able to see. So people who have not seen this lenticulostriate vasculopathy before can watch this image. I have our own case also in the subsequent slides. So here in the angled parasagittal view, you get this lenticulostriate vessels normally. If you put a Doppler, it will be showing like 3 lines or 4 lines where the blood flow is going into the lenticulostriate via the lenticulostriate arterioles. When there is torch infections, what happens is the calcification is present across the lenticulostriate arterioles, and you see this as echogenic vessels in the angled parasagittal view. So here we don't have any doubt at all. Here we have this calcification seen all over the ventricular wall. Here we have calcification seen in the ventricular wall, calcification seen. Okay, here you have this echogenicity in the ultrasound. You have a echogenic spot, which is a calcification. You are able to see in the ultrasound cranium in the frontal area. In the MRI, it is appearing like a hypointense lesion. Here, when you do a CT, you will be able to see this periventricular calcification. It's a cytomegalovirus. Okay, so we had a baby A who was a 31 weeker, 815 grams, intrauterine growth restriction. Baby had persistent thrombocytopenia. Baby had cholestasis. Baby had hepatosplenomegaly. Initially was managed like a preterm baby only. Why this baby is having persistent thrombocytopenia? Then developed cholestasis. Baby had prominent hepatosplenomegaly. So, okay, I also, they told baby, the ophthalmologist examined and told chorioretinitis is there. So for hepatosplenomegaly, when the ultrasound abdomen was done, it was showing some calcification in the liver. It was also showing diffuse calcification in the periventricular area. So in the thalamus, you can see, no, here in the thalamus, caudate area, everywhere spots is it. So this is a caudate and this is a thalamus, no, everywhere in the thalamus also you are able to see, in the basal ganglia, you are able to see the calcification. This is typical of toxoplasmosis. Okay. So in the same baby, when we did this angle parasagittal, you were able to see, when you put Doppler, normally only some blood flow will be present. But here we were able to see prominent lenticulostriate arterioles. This is due to calcification across the lenticulostriate vessels as well. So this is called as lenticulostriate vasculopathy, which is always present in mostly present in a torch infection. Cytomegalovirus, toxoplasmosis, all these things have lenticulostriate vasculopathy. So we can have cystic transformation, we can have some ependymal cyst, we can have calcification restricted only in the periventricular area or a diffuse calcification like what we saw here in the toxoplasmosis. So random calcification in the Zika virus. There is most of the time, baby might have some of the features. Baby can have some hepatosplenomegaly calcification, and but baby doesn't have chorioretinitis. I have sent a torch serology. I have sent a urine CMV PCR. I have sent a Zika PCR. Everything is negative. So the same close mimicker of torch infection is a pseudo torch. We call it as Aicardi-Gouttier syndrome, Aicardi-Gouttier syndrome, where the baby will present, baby can have microcephaly, can have extensive calcification. They mimic like torch, but all your serologies are negative. So this is pseudo torch or Aicardi-Gouttier syndrome, which needs genetic testing. Okay, so lenticulostriate vasculopathy we saw. So let us wind up with some take-home messages. These take-home messages are not for any particular condition. This is general take-home messages when you make up your mind to do a ultrasound cranium. Clinical differentials have to be ascertained based on the history and physical examination. So when did the fetal growth restriction start? Whether it was early or whether it was a late FGR, and whether the torch serology was done in the mother. What is the previous obstetric history in the mother? After birth, also physical examination in the form of like what is the head circumference centile, what is the Z score, even if it is a IUGR baby, symmetrical IUGR, what is the ponderal index, what is the head circumference Z score, whether there is hepatosplenomegaly, whether there are any blueberry muffins, petechiae, ophthal red reflex is present, or there is a cataract. So these are all very basic examinations which is must for any baby, that has to be done, and you should have a clinical differentials for any case in your mind before touching ultrasound machine and before interpreting your findings. So always interpretation of your findings should be based on the clinical history and physical examination findings, and you should not come to a conclusion based on a snapshot in most of the conditions. Most of these conditions require serial monitoring, especially the PVL. So all this requires serial monitoring. And always, whenever you are telling some pathology, whenever you want to confirm, you are assigning a diagnosis to the baby. This should not be based on a particular view. I did C3. Now I am labeling the baby as grade 3 IVH. That is not acceptable. I did C3. I found something echogenic. I am labeling the baby as periventricular leukomalacia. That is not acceptable. So you need to do all the views, coronal view as well as sagittal view, to confirm your diagnosis, to grade your pathology. So that is needed. The diagnosis should not be based on a single view, single plane. So thank you. I'm open to questions. Thanks for the opportunity again.
And thank you so much, madam. I think it was very informative and excellent session. I think it's open for the question and answer. I think uh, you can directly ask the question by unmute yourself or either put in the chat box.
Mohit sir is also there. Welcome, Mohit sir.
Good afternoon, sir.
Good afternoon.
Good evening, Kunal.
Good evening.
Sir.
It was a great session. I was listening to it, and as usual, Dr. Usha, it was very nice. Thanks for accepting and presenting this,
Thank you.
and very helpful for us. And it will be. I was just checking on my desktop about the previous sessions of all the Pathshala and POCUS series on our YouTube channel. So I was just checking the number of views and everything. So thank you for being a part of this.
Thank you, sir. Thank you for the opportunity, sir.
Thank you so much, everyone, for giving us the opportunity to host the session. So, with everyone's permission, can we
Yeah,
close the session over?
Sreyanshi, wait. We are waiting for question answer, please.
Oh, okay. Okay,
Sorry,
sure.
sorry. It's not
No
finished.
issue,
Sorry.
no issue, sir.
if there are any questions, you can keep post it on the chat box, or you can ask directly, unmute and ask also. I think there are no questions. Vishal, you can.
Yeah. So I think it was very nice session, and I think rightly said by Kunal, like in initial part that it is an untouched area, and apart from IVH, we need to rule out this kind of things when you do a routinely ultrasound. Like don't look for only the IVH, but also white matter injury, cerebral abscess, torch infection, which are I know the incidence would be less, but again, when you are dealing with the preterm baby and like IUGR baby, we need to rule out this all kind of thing. And I think it is very excellent session. And thank you so much, madam, for doing this session.
Thank you, sir.
So we can wind up the things. Yeah.
Thank you so much.
Sreyanshi,
Yeah, thank you so much, ma'am. It was a wonderful session, and with all
Thank you
the
so much.
images also.
Thank
It
you, sir.
was
Thank you, everyone.
presented. Thank you, Vishal.
thank you,
Thank
ma'am.
you, clear now. Yeah, we can wind up.
Thank
Thank
you,
you,
sir.
Mohit sir. Bye.